Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. My name is Terry Fletcher. We are at our 119th episode of the CodeCast today. It's the last Tuesday of the month. Where did January go? But that means we are at the Top 10 Tuesday segment that we do at the end of each month. And it's funny because this morning I was actually just on the Talk 10 Tuesday with ICD-10 Monitor, talking with them this morning on their live broadcast. So, boy, say that 10 times fast. So Top 10 Tuesday for me, Talk 10 Tuesday for ICD-10 Monitor. If you ever get a chance to listen to that, I know some of you aren't part of ICD-10 Monitor as a member because that is a paid service, but you can always listen to the episode that they turn into a podcast for free on all downloadable platforms. Just look for Talk 10 Tuesday afterwards. So it's usually at the end of the day on Tuesdays. So anyway, let's get started. So for our Top 10 Tuesday today, I'm going to spotlight modifiers again, but I'm going to focus on Hickspicks modifiers. So the modifier series that I've been doing over the last 6 months, as you know, have been really popular. So I thought it was a good way to get in 10 of them today and discuss the most popular Hickspicks modifiers. And those are different than the CPT numerical modifiers that you find in the back of the CPT book in Appendix A. These are in the Healthcare Common Procedural Coding System Manual. That's the acronym Hickspicks. And it's a standardized coding system necessary for medical providers to submit healthcare claims to Medicare and other insurances in a more consistent and orderly manner. So Hickspicks has two coding systems. They have, or code sets, I should say. They have level 1 and level 2. So the level 1 goes hand in hand with CPT, and that's most of the AME CPT codes, and that's primarily numeric. The level 2 of Hickspicks codes, that's a standardized coding system that is used primarily to identify products, supplies, and services not in the CPT code book, such as ambulance services, DME, which is durable medical equipment, prosthetics, orthotics, and supplies. And so a lot of these are also used outside of physician's office as well. But because Medicare and other insurers cover a variety of services, supplies, and equipment that are not identified by CPT codes, these were established in the mid 1980s. And level 2 codes are also referred to as alphanumeric codes because they consist of a single alphabetical letter followed by 4 numeric digits sometimes, while CPT codes use 5 numeric digits. But also when we're dealing with Hickspicks, I'm just going to talk about the modifier part of those. And so it's going to be the 2-digit alpha modifiers. But first, the CodeCast podcast is brought to you by the Mayo Clinic, an integrated clinical practice, education, and research institution specializing in treating patients, the #1 hospital in the nation. Nowhere to go. Minnesota, Florida, Arizona, mayoclinic.org. The CodeCast is also brought to you by Keck Medicine of USC, over 500 internationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, Los Angeles, California. Okay, now on to our modifier discussion. And these are the top 10 Hickspicks modifiers for 2018-19 based on usage that was put out and published by Part B News and also a CMS, a couple of the providers and a couple of the MAC carriers. And we want to make sure that not only do you know how to use them, but what they're for, but also that you're compliant, because the misuse of these codes, or I should say modifiers, or not using them at all could cost your physicians plenty. And we want to make sure that we are on top of the reimbursement situation. So number 1 is the Gw Modifier. So G as in girl, A as in apple. Waiver of liability statement issued as required by payer policy is what that modifier is. So it indicates that an ABN, or Advanced Beneficiary Notice, which is a waiver, is on file and signed in your office by the patient, and it allows the provider to bill the patient if not covered by Medicare. The use of this modifier also ensures that upon denial, Medicare will send you the EOMB, that's the attachment to the check or the explanation of Medicare benefits or remittance advice, with a PR code, that's a payment code, and that's patient responsibility. So if something is denied, it'll say it's patient responsibility, and that way you can bill the patient. And we use these for screenings, diagnostics with frequency guidelines, or anything that has exhausted benefits. So these modifiers basically, it's helpful because this modifier can address a situation where a patient says, oh no, you should code for it or report it because my secondary is going to cover it. And we know that a lot of times when Medicare's benefit has been exhausted or your frequency guideline has already been met, so let's say you're trying to get an echo, and so an echocardiography. Well, you're allowed to have those once every 6 months. Well, let's say the doctor wants you to have one in the office within a 3-month time period. Well, you may get a denial because your frequency guideline is a problem. And so a Gw Modifier will suffice that because you now can go after the patient for the reimbursement. Number 2, the Gw Modifier. So this is used when the physician is providing a service that is not related to the diagnosis for which the patient has been enrolled in hospice. So this physician is not associated with the hospice and is providing services as the attending physician. So remember, when a patient is nearing their end of life and they elect to enroll in hospice, they waive all rights to their Part B services related to any of that hospice Part A stay. So an example would be a beneficiary enrolled in hospice goes to a physician's office for, let's say, a closed metatarsal fracture, which that's the fracture of the foot. And the physician wants to bill the 28470 for fracture care of a closed metatarsal fracture. Well, to do that, if a patient is enrolled in hospice, your physician would have to bill it with a Gw Modifier, so 28470. Otherwise, it won't get paid. It'll say the place of service is not appropriate. And that happens a lot of times, so just make sure you keep that modifier handy in case you need it. Number 3 is the Jw Modifier, and this is a Hickspicks modifier level 2 used on Medicare Part B drug claims to report the amount of drug or biologic that has been discarded and eligible for payment under the discarded drug policy. So the JW is only applied to the amount of the drug or biological that is discarded, and in a situation in which the Jw Modifier is not permitted is when the actual dose of the drug or biological is administered is less than the billing unit. So make sure you look this up in the Medicare Claims Processing Manual, Chapter 17, Section 40, but it's actually mandatory. It's an inventory control modifier that allows you to get paid for unused or wasted medication and drugs. So it's something you want to look at. Number 4 is the KX modifier, and I always feel like this is a misunderstood modifier because it means different things on different services. So this indicates that a supplier has insured coverage or coverage criteria for the DME billed, and they have met that criteria, and the documentation exists within the patient's EMR or paper chart, if you're still using paper charts, to support the medical necessity of the item. So if you add the KX to the claim, you're stating that your claim has met specific documentation requirements in the policy and would be available upon request to any Medicare carrier that asks for it. I've seen this used on claims where there's been a payment cap, let's say for physical therapy. And so right now it's $2,010 per calendar year. And so if the physician still feels that there's certain therapies the patient needs that's medically necessary, there's an option to add a KX modifier to additional therapy codes. Now, it's not a guarantee of payment, but I have seen that Medicare will allow, a couple of 3 visits after that if it's appropriate. I know that I instruct my clients on pacemakers. So if you have patients who have sick sinus syndrome or certain atrial fibrillation diagnoses, then a KX modifier can make sure that claim on that 33207 or 208 is pushed through. So look at that modifier as basically your medical necessity modifier. That's really what it's for. Now there's something called a PT modifier, and that's number 5. P as in Paul, T as in Terry. That is for colorectal cancer screening converted to a diagnostic test or other procedure. And this is amended to, let's say you did a biopsy, 45380. So what this is let's say that your patient came in for a screening, okay, and they expected to get no deductible or copay. Well, what happens is that even with sometimes the diagnosis, the payer, if it converts to a diagnostic test from a screening, they'll still charge the patient their full out of pocket, which is incorrect. Adding the PT modifier to the CPT code indicates that a scheduled screening was converted to a diagnostic or therapeutic procedure, and it triggers benefits. Now, it won't waive their copay, but it will help waive their deductible as long as they've met the frequency guideline benefits. So just keep that in mind because it can be very helpful, again, for patients when it comes to their out-of-pocket. Which leads us to number 6, which is the modifier 33. That's used the same way in the screening example, but this indicates a preventative service in which the patient's copay, deductible, or coinsurance is waived. I use this also on screening aneurysms. Anytime there is a screening under the U.S., they call it U.S. Task Force, and it was under the Affordable Care Act, then this modifier can help to trigger benefits, meaning that the patient's out of pocket, for the most part, is waived if it stays a screening or if it converts to a therapeutic service. Now, you don't use this if you don't use a 33 modifier if a service is what they call inherently preventative. That means, let's say, the annual preventative medicine visit code, the 99381 to 99397. You wouldn't put a 33 on there because the descriptor says it's a preventative service already. So you don't need to tell the payer that again. Now, number 7, I wanted to revisit the X modifiers, just one, because CMS updated their claims processing direction last month in December 2019. And this was huge because they haven't given us any direction since these new modifiers came out in 2014. So when I went over this already in my 59 modifier spotlight, I don't want to go over that again, but I do want to go over some of the one new direction they gave us. And that is for the XE modifier. That's the separate encounter. So this is a service that is distinct because it occurred during a separate encounter. And again, this is a replacement if you were planning on using the 59 modifier. And this modifier should only be used to describe separate encounters on the same date of service. So a great example is if a patient has 2 surgeries on the same date, but at different encounters. And this is a huge reimbursement modifier. If the 59 was used instead, you'd basically be telling the payer that both surgeries were done on the same date, but you're not necessarily telling them that a different encounter was had. And so if that reads as the same session or same encounter, then your physician's going to be reduced 50% for multiple surgery guidelines. But with the XE showing that it was a separate encounter, then that shows that the physician and patient left the OR or procedure room and then had to return back, and that therefore they should be allowing 100% of both services. And it's tough when they land on the same claim form, but that is probably one of the biggest reimbursement modifiers, payment modifiers that's out there under Hickspicks. So remember, there's so much change out there and so much revenue just left on the table by incorrect use and forgetting how to use certain modifiers that can help you. Modifier GG, this is defined as the performance and payment of a screening mammogram and diagnostic mammogram on the same patient on the same date. So in my experience, extra mammogram views to further investigate a potential problem seen on the screening mammogram are typically performed on a subsequent day. Not all the time, but often. So if this happens, this is your modifier. But also, you should know that most insurance plans cover screening mammograms in full based on age and frequency appropriate, but diagnostic mammograms are not covered the same way. So patients, who have the diagnostic mammograms may owe copays at the doctor's offices and receive bills if the scans are subject to their plan's cost-sharing terms and haven't met their plan's deductibles yet. So keep that in mind that this modifier is also helpful when it comes to the patient's out-of-pocket as well. Number 9 is the Hickspicks modifier AI. And the AI modifier identifies the physician that oversees the patient's care from all other physicians who may be furnishing specialty care as the admitting physician. The AI means admit inpatient. So only the principal physician of record may submit this modifier. You're also the one that's going to get paid for the discharge. And so that's why this is an important modifier. It can be submitted on any 99221 to 99223. That's the initial inpatient hospital codes, or any of the long-term care nursing facilities or SNFs 99304 to 99306 codes. And again, this is an admit inpatient modifier. Absolutely important if you're trying to identify yourself as pretty much the physician who's admitted the patient and now is in charge of their care as it moves forward. And number 10, these are two easy ones. I thought I'd end with that. RT-LT, right and left side of the body. Check with some payers. Some only allow this for x-rays and not surgery codes, but the RT-LT is very payer driven. It denotes laterality, so right and left side of the body, and very helpful if you can link that to a procedure that also is linked to a diagnosis code that has identified laterality in the code. So if you're dealing with lower extremities, and let's say that you're doing a stent on the left side iliac, which is in the leg and the thigh area. So you'd have 37221 LT, and also your atherosclerosis should have in the lower extremity should have a laterality comment in it as far as what side of the body. So that could just help you with the payer where everything syncs up and it's consistent. And so then you wouldn't have too much of a problem there with reimbursement. Okay, let's talk about our coding question today, and it comes from one of my California subscribers, and it says, Terry, I'm new to cardiology, and I recently saw Swan-Ganz catheter in my cardiologist documentation. Could you explain what that is and what procedure code I should use to report this service? So sure. Okay. So you should report a Swan-Ganz catheter with a 93503 and no modifier. So this is insertion and placement of a flow-directed catheter for monitoring purposes. So what this is Swan-Ganz are designed for specific hemodynamic monitoring and central access. So your physician or provider can use these catheters to monitor pulmonary artery pressures. Plus, they can measure cardiac outputs and other cardiovascular functions, and that's why they leave it in. And it also has multiple ports for central circulation access. So it might have a regional anesthesia port. You might see in the documentation RA, a PA port, which again is the pulmonary artery pressure, or a CVP port, which is a central venous port, and possibly the main line or introducer as well. Now, where you can get confused, especially if you're new to cardiology, is that Swan-Ganz catheters are also used for diagnostic right heart caths. And so where they may or may not do an injection, but they're looking at the right heart, which means they're looking at the heart that also has input, or I should say impact on the lungs. And so here's the rule. If they take it out and they use it, it's a right heart cath. If they leave it in, it's a Swan-Ganz. And the right heart cath, the 93451, needs a 26 modifier. That's only worth about $124 to about $180, depending on your payer. And the Swan at the 93503 no modifier is worth anywhere from $300 to $400. So you want to get this right so you're not over or undercoding as far as coverages. So that was a great question because that can be very confusing. Today's coding question is brought to you by HealthTerm, 100% web-based enterprise terminology system that enables data exchange and semantic interoperability in healthcare, a product of CareCom, carecom.com. So I'm going to end this week with my personal insight, but it's also about your career, and it's about getting your new CPT book. I heard a funny phrase this week, and not funny, haha, just funny like this is a great analogy on what it means to not get your new book and your new, make sure that you're updated. I know some of you think you can live without it, but think about this. It's like leaving a party after too much to drink, getting in your car and deciding, should I Uber? By the way, yes. Or should I risk the DUI? By the way, no. So you're taking a risk with your practice, your physician's livelihood, and your own career life if you don't get your new book. It's your career, own it. And the only way to do that is to be updated. I get a lot of questions, how can I be a consultant? How can I, really showcase my skills in this industry? And it's to be current, it's to be updated, and it's to know what you're talking about. And the only way to do that is to use current authoritative references so that you can say for 2020, this is what is accurate and what is now. Otherwise, if you're looking back at a 2017 or 2015 CPT book, even ICD-10 book, you lost your credibility. So even though this was my personal insight, it has to do with your career. And I really am here to help you with that and make sure that you're always pushing forward, you're always inspired to do better, and that you know what it takes to really move in the healthcare world as a professional. Before I end today, I wanted to shout out some people that just have been sending me some really nice messages on LinkedIn and on Instagram, and I haven't done that in a while. So Ruth, hello, I hope you're doing great, and I know you're going to find that perfect job that you want. Now, this one is hard to pronounce. Marlene Guy, I think. Moreno, I think that you're going to be doing great. And thanks again for that endorsement on LinkedIn. I really appreciate that. John, and thank you so much from AAPC. I really appreciate you listening and always appreciate my listeners. Dan and Mindy and Tony, it's great just to have you all on board, and also Josh as well. Anya, I saw you on there as well. And just want to make sure that everybody knows, if I can see you and I can get some feedback from you, I'm always happy to shout you out, and always looking forward to my listeners who really just let me know that you appreciate the information. So again, great to hear from everybody. So everyone, make it a great day, a great week, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.